What's up, folks? Welcome back to another nursing debriefing right here. Matt's still hanging out in Chicago. I'm still here in the wonderful San Diego. But Matt, so how have you been doing over there in Chicago, man? You miss me or what?
Yeah, dude. It sucks not being able to nurse, hanging out, surfing, doing whatever, going on some hikes. But I've been enjoying my nurse break, to be honest. I'm getting pretty lazy trying to go back and pick up the shift. I moved to this city, so I've been kind of giving myself some time before I pick up the shift. Last week, I finally had the ability to go to that staffing agency that I mentioned, so I filled a whole nother skills checklist out. Let me tell you, it took 2.5 hours, so that was a drag. Filling out stuff manually, doing questions about defibrillators and drugs. There was some questions that were goofy as hell I've never heard of. I'm like, I don't know how an ICU nurse can pass this sometimes. Got that done, took the physical. A little life hack, you do the same thing for anybody listening. It's awesome if you could put everything on a Google Drive as far as your documents, certifications, any paperwork, your immunizations. It just saves you so much. Or even your job history. If you create an Excel with where you worked, some contact information, it makes it so much easier when you're applying to multiple places as a travel nurse or seeking a travel staffing position, PRN. So that's what I picked up. And yeah, next week, basically the way this works is you get a text message of what are the needs for the week or maybe for that day. And you could pick up a shift. They text you, they tell you where to go. And it's that simple. So we'll see how the process is. I'll talk about it in the next debriefing. I'm only kind of interested about what hospitals they choose. What are the uniforms? Because here there's a lot more dress codes like CO Blue and etc. And then I'm kind of debating on which charting system I should go with. So we worked with all three, but honestly, the last one we worked with Epic. So probably it'd be better to get a hospital that works with Epic.
Yeah, usually Epic solid and so was Cerner. The one that we did in Texas, Med something. Remember the name of it?
So yeah, Meditech. And there's a few hospitals that have it here, so I might just opt out of those.
Yeah, that's old school, man. That's old. But actually, it's super old school, and it sucks looking at. But charting is so much easier on it because you don't have to chart as much. I feel like it's just when you look up stuff, it's just hard to find, and it gets really frustrating and really annoying. But something that we talked about before we hopped on this debriefing is because I was thinking about picking up a shift, and then you told me to maybe apply to this agency and then pick up a shift to that agency because you mentioned that once I work over 40 hours, then I get taxed a lot, and with this, you mentioned something else that it will be a different tax bracket. What were you saying?
Yeah, so if you are on a travel nursing contract and you pick up a shift, you're going to go over your 12 hours for that facility, for that employer. So instead, I talked to a travel nurse there. I got a contact where you can find a local position, staffing agency that works PRN contract. And it's the same basis here where you get a text, you figure out where you want to pick up, and you go work. So you can do the same thing where you are going to be taxed through that company, but you won't be put into the higher tax bracket for the OT where they start taxing you a lot more. So that's something to test out to see where you can make more money if you are a travel nurse on contract. That's doing 36. If you do 48, I doubt you're going to pick up a fifth shift that week. So if you're doing just 36, maybe it's better for you to do a PRN at an agency locally in your state, city versus your travel agency.
Yeah, like a little travel nursing hack that not people know about. Because remember in Texas, in Austin, we met that nurse that we used to work with in Santa Monica, and that was during the winter time. So a lot of nurses were doing 5 shifts or 6 shifts per agency. And what he did is he said he works for 2 agencies and he just does 3 days per each agency, and that saves him a lot of money on taxes. So that's like another hack. So if you want to work more than 3 shifts, we recommend going with a second agency, or like the thing that Matt said is to go on this other agency where you could just pick up shifts here and there.
Yeah, and the way with nursing, I feel like there's so much short staffing that they need nurses so much where if you work your 3 days in a contract, you could tell them like, hey, I'm available Monday, Wednesday, and Thursday. Let me know. And more than likely, they're going to be able to manage that schedule to get you in because they're desperate and they have needs.
Yeah, 100%. Like I left this morning and it was crazy because we had 4 ICU patients. We had 5, but then I transferred mine right before I left, and we had 4 ICU patients, and 5 nurses got floated to different units. That's how, and all the units were still short nurses. So today was a rough day for days because every unit is super short, missing brake nurses, not enough CNA. So there's like still a giant shortage, even though it's kind of like the off season of nursing. There's still a giant shortage everywhere. And if there's a shortage in this facility, I can only imagine other facilities that aren't as great or not of this caliber.
It sounds like the summer rate stuff, prices going down is a myth. In this case, the rates should be staying up if they're that short.
Yeah, man. I wish I was renewing my contract right now, because I would definitely argue for more, because I know how super short they are, but I recommitted back in April, so I'm stuck with this pay rate in August. And I don't mean stuck in a way that it sucks. I'm still making quite a bit of money. It's just lower than what the winter rate was, of course. But no complaint.
There's always opportunity for more. How's your shift been, man?
They've actually been pretty interesting. Last debriefing, we talked about the pacemaker that I had, the transvenous one that felt like a real ICU patient. And this time around, I actually had a Swan. So I haven't dealt with pulmonary artery catheters in like a couple of years, I want to say. Maybe not a couple, probably like a year and a half-ish. Because I don't think we did them in Texas. I don't think they had them in Texas because if they did, they didn't give it to us, because I don't remember having one. Did you remember having a pulmonary artery catheter in Texas?
I don't think so. No, I just had... I don't think I even had a CRT. I had a critical patients on pressors, but never a Swan.
Yeah, I think the last time we've seen it was Santa Monica, which is like a little over a year ago. But yeah, but I had a Swan this shift, and it was pretty cool because I used to work with Swans all the time, so I was very experienced. And they're trying to figure out in the mornings, or not in the mornings, but when we came in at night, trying to figure out who to give this Swan to. And I was like, yeah, just give it to me. I'm very familiar with Swans. I like doing them, and I took it, so I kind of saved the unit a little bit, because there's some nurses that weren't too confident with it, which is okay, I don't mind doing that. And plus, I felt pretty cool taking the sickest patient in the hospital. So yeah, so this lady had really bad pulmonary hypertension. She came to us with severe edema, shortness of breath, and we actually don't put Swans in our facility, so we sent her out. She got a Swan placed, and then they brought her back in. So I had her pre-Swan and when she got her Swan. So she was on a medication called Epoprostenol is the word for it, if I'm pronouncing it correctly. But it's a medication that works on your prostaglandins, which dilates your pulmonary vasculature. So with pulmonary hypertension, you're very constricted in your pulmonary airways, so this helps with that. And it was interesting because it's like it's like a battle between how much pressors you put her on versus how much EPO she gets, because you don't want to constrict something that's already constricted, and you don't want to relax something too much, because then you're not going to get the proper perfusion. So I had her on Bumex, the EPO, dobutamine at 2.5, and then I had her on Levo as well. So it was like a fine balance between how much Levo do I give her versus how much EPO. So it was a very complicated patient. She was very, very sick. Her PA pressures when we got her with that Swan were like 70s over 40s, and that's a crazy high pulmonary artery pressure, because normally when you think of pulmonary artery pressure, you think of quarters over dimes. So 25 over 10 is a good number to be at as a standard human being and being a healthy person. Hers were 70s over 40s, which is super high. It's almost like a blood pressure that you would see on the patient sometimes. And what was really scary was that her arterial pressures were 80s over like 50s. They would go 90s over 50s, and then her pulmonary artery pressure started to go up a little bit. They got as high as like 85 over 54, and that was being super close to her arterial pressure, which is super scary, because if you don't have enough pressure to push your blood through the heart or through the lungs, your heart's going to basically stop. It's not going to be able to beat, because you don't have enough pressure pushing against these things. So it was very scary. She was a very, very sick patient, but it was cool because we were diuresing her. We were trying to dilate her pulmonary vasculature while at the same time constricting her other vasculature, so we could maintain hemodynamic stability. Her CV.
Quick question: that medication, the Flolan Epoprostenol, is it being given also for the reduction of the SVR?
So it's interesting because her SVR was actually normal. If I remember correctly, it was in the 900s. Okay. Which isn't super high. It wouldn't really decrease the SVR because it's only working on your pulmonary airways, not necessarily your.
That's more the afterload when it's
exactly.
In the gotcha.
Yeah. So I was actually surprised at her. Well, now I think about it, I think it actually does dilate a little bit because there is some systemic effect. So technically it would decrease the SVR a little bit, I'm assuming. But then I had her on the Levo, which then increases the SVR because it constricts it. So I'm thinking since her SVR was normal and she was on Levo, then the Levo was constricting it, but then the EPO was also probably dilating it a little bit because her SVR was normal. With levo, you would see a higher SVR because you're increasing the constriction.
Yeah, the beautiful dance of working in the ICU and managing multiple drips.
Yeah, it was super nice. Yeah, so we had her on Bumex of 6. We were diuresing her super hard. Her CVP was like 11, 12. So it was stuck at that. We wanted it a little bit lower, like in the 8s, 6s would be more ideal. But she was putting out a lot. But then again, she was on a lot of drips, a lot of medication, so she was getting a lot of fluids too. So it was very complicated. So let me just explain to y'all what a pulmonary artery catheter is. So it's a catheter that it's a central line, but it goes further than the vena cava. It goes all the way to your pulmonary artery. So it goes through your right atrium, right ventricle, then it goes through the pulmonary valve all the way to your pulmonary artery. And then the other valve that it goes through is your tricuspid. So the right atrium through a tricuspid valve, right ventricle, then through the pulmonary valve to the pulmonary artery. And then we could also do wedge pressures, but they don't allow nurses to do wedge pressure, so I didn't get a wedge pressure on her. And I really like Swans because you get a CVP off there, you could draw blood off it, you could push meds, you obviously got the pulmonary artery pressure on there. So it's really cool. It's just a high risk for infection, so we don't want to leave them in too long. Like I said, you could check very accurate CVPs because you have a transducer that's also has a little sensor sitting in the right atrium where the lining goes, because sometimes we do CVPs off central lines and those just sit in your vena cava, which might not always give you the most accurate numbers, and this one gives you a lot more accurate numbers. And of course, when you wedge, like I mentioned, you could check all those other pressures, and it's cool when they put the Swan in, while they're putting it through your heart, they're checking your right atrium pressures, your right ventricle pressures, and all that, which is also real cool. You get a really good understanding of what's going on with your patient. So that's a little spiel about pulmonary artery catheters right there.
Yeah, if you're an ICU nurse, it's awesome to have one in because you could troubleshoot so much and figure out what's happening with the patient. I know we're talking about Epoprostenol. Is your unit or hospital experiencing any shortages in medications? I know when I worked there, last contract didn't have like the 50 cc bags for antibiotics, and we had to like jury rig it into the 100 cc bags and etc.
No, we're good. We're stocked up. The only thing I think we have a shortage on is Ativan, but not in the ICU. I think it's other floors. They're stocking the ICU, but I know that when I floated prior shifts before having this patient, they were saying, hey, if you need Ativan, call pharmacy, and they're going to send it down. And one thing I forgot to mention about the pulmonary artery catheter is you could get a mixed venous off that. So with the mixed venous, you draw that off the port that's in your pulmonary artery, and you pull it back slowly, and you're getting a mixed venous. So you're getting a sample that is going to the lungs. So you're getting blood drawn from the area that's last to go into the lungs. Right before it gets reoxygenated, you're getting that blood. So you're able to assess and evaluate how well your body is using oxygen. So for example, if it's high, it means your body is not absorbing the oxygen. So what's the issue? It could be sepsis. Sepsis is interesting because it could be low and high. Usually it's low in the beginning and then high later on because your organs are just not able to properly absorb that. And sometimes if it's low, that could be a sign of heart failure because your body is not properly pushing blood through your circulatory system. So your blood is more stagnant and your organs are able to absorb more oxygen, which they need, but which is a good thing. But then again, it's a bad thing because why is so much oxygen being absorbed? So it's like a very good assessment of how well you're perfusing your organs and what's actually going on.
Yeah, that's a solid understanding of the Swan. For my skills checklist, I think I put like 3 on 5 on the Swan because it talked about setup. I don't think I'll be able to set up a Swan if I just get a patient that needs one. If the Swan is there, I could probably figure out everything I need except for pushing the cardiac numbers. I just need one rundown wherever I'm working to tell me how to do it, and then I'll be good to go.
I'm actually glad about the numbers because we call it thermodilution. So you want to have a bag of D5 that's hooked up through a special tubing that goes into the right atrium, and you basically push about 30 mLs of the D5, and what it does is it senses the temperature of the initial push of the fluid, and then all the way through the catheter at the tip it senses it again, and through this temperature change you're able to see your cardiac output and your cardiac index. And make sure it's D5 because the machine, the monitor that you have, it's programmed for a D5. So let's say if you use saline, it's going to give you an inaccurate number. You got to use a D5. I'm not sure what the rationale is, the difference between like the thermodynamics of D5 compared to 0.9, but you're always supposed to use D5 when you do your numbers. And it's always good to do it like 3 or 4 times. I try not to do it too much because remember, this patient isn't a heart failure usually, so too much fluid isn't a good thing. And if you're pushing it 5 times, you could be pushing a lot of fluid in them. It might not seem a lot to you, but it might be a lot to the heart.
Yeah. I'm kind of brainstorming right now, thinking of how it's going to be picking up a day shift, because we've only mostly done nights. We've done that one contract in LA for day shift, but I feel like it was very cush, meaning there was a lot of resources, and I think day shift was pretty nice there. So I don't know what to expect working in Chicago on days.
Right, and it's always harder to onboard during the day shift, because on nights you kind of get a feel for things. Things are a little bit slower. You can ask more questions. You could troubleshoot things more slowly, you could say. In days, you just tossed in it, and you got to figure out where X-ray is, where CT is, where all the units are. Compared to nights, where you kind of get away with not maybe knowing the floor plan of the hospital. But yeah, it's gonna be tough trying to figure out where everything is and how to move your patients.
Yeah. I mean, yeah, thinking about it right now, there's like a slight of anxiety, meaning how are things going to be? How are these doctors? Because we don't worry about with doctors so much when you're working nights. Then there's the huddle, whatever they do in the beginning of the shift, where they talk about the patient. How well will I be managing the patient, looking at the chart, talking to the doctor in days? Then you got to feed them. There's insulins, but that's, I feel like sometimes that just creates a lot of like worry, and you just try to zoom out and out of the seed that you're in, the worry, and into the bigger picture of the world. And just be like, you know what, 12 hours just gonna work the way they work. It is what it is, right? You just come in there. What's that? We had that quote last time. It's just an experience, right? For floating, just go in there and learn and see what happens.
Right. No more DSPs. You are the DSP, bro.
I am the DSP. It's gonna be. I'm going to be on the report sheet. Usually you don't write down as much as a night shift nurse, but this time I'm going to be flipping it back and forth. Okay, all these notes I need to tell the doctor, all the stuff that wasn't done for nights, all the concerns that night shift had that maybe we should tell the doctor. Those are little notes that we're going to be taking versus on nights. It's like, okay, let me just be the investigator all shift for 12 hours and see what days needs.
Right. Good thing we had a couple of nurses report sheet, right? That's a ton of come in clutch, especially the ICU one. And yeah, it's gonna be tough, but you're definitely you're very resilient, you're smart, you're definitely gonna be able to pull through it. It's probably just gonna take you a little bit longer to figure out what physicians want to hear, because you're gonna be doing maybe a shift a week or a shift bi-weekly or however often you do it. It's gonna be kind of tough trying to see what physician requires what, especially if you have different physicians coming along. Cardiologist is a cardiologist, but a cardiologist might look at a different number versus another cardiologist. So that's always all kind of fine tuning to who you're going to be speaking to, basically.
Yeah. The beauty of nursing, man, every single unit, state, hospital just has a different way of doing things. And it's just a fine little dance of life in the ICU and the healthcare in general.
Yeah. Yeah, for sure, man.
All right, ladies and gents. Hope you guys enjoyed this nursing debriefing. We'll see you guys in the next one. If you guys like these, hit the like, hit the comment, share it. If you want to hear something specific, drop a comment, and we'll see you on the next one.
Yep, thank you so much, guys. See you next time.